You're welcome. Thanks. Maybe we go to the next case. Very nice case. Beautiful presentation, Diogo. Thank you very much.
Thank you, JP. Good morning, everybody. So the second case is titled Cushing's disease or Cushing's syndrome. And this is the multidisciplinary team that was involved in patient care. We had Dr. Chaichana, as well as Dr. Almeida from neurosurgery, then Dr. Miller from radiology, Dr. Wessel from neurosurgery, ENT, Dr. Donaldson, Dr. Sampson from endocrinology, Dr. Gento from pathology, and will be presented by Dr. Schulz and myself.
Okay, Tanu, just pause for a minute because Dr.
Yes, sir.
Vargas asked a very important question that we didn't really deal with, and that it will also been racking our brains. Gabriel, we don't know how to explain the leptomeningeal disease. That's why everybody was so intrigued about this. That's why we had a massive workout with neurology, inflammatory.
Yes.
Susan was nodding and smiling because we still do not have an explanation, to be honest with you. But I don't know, maybe you have an explanation. You haven't thought about this.
No. That's amazing case, and of course that when we see that kind of things, as you thought, missing inflammatory disease or something like that, have you work out, but nice that you have an excellent pathology there, very quick response on that. We don't have that here, and then that's something that really we miss. That pathology at the operating room is one of the things that we need to have, and we cannot deal with that kind of thing. So very nice, very excellent case, and thank you, because yes, it's not easy to explain that leptomeningeal in that diagnosis is curious at least.
Well, it's a blessing to have Mark, to be honest with you. I mean, it just because you're absolutely, what happens is that we don't have some sort of idea what's going on. The intuition of the surgeon is, I need to go back and get more. And next thing you know, you are digging into someone's hypothalamus. And I got to tell you, it is happened to all of us, where that patient begins to have a huge number of issues. And Fred Meyer presented on Monday. You saw the conference where he said, I kept going in the hypothalamus, and now this patient is 300 pounds heavier, eating the carton of the pizza, and I have exactly the same. Immediately, he refreshed my memory in a patient that I did that, where I kept going and tried to get more and more tissue, at a different institution, and not really knowing what was going on. But in our attempts to help the patient, we ended up creating more harm than help. And it's difficult for us to deal with that. And Susan, you were about to say something.
No, I've had patients that had to have a lock on the fridge door because of hypothalamic obesity, and so I'm just nodding that I appreciate your understanding of that situation for sure.
Sorry, Diogo. We just needed. Gaetano, we needed to pause for a minute.
Sorry,
Go ahead,
no
Gaetano.
problem,
Keep
no
it
problem.
going.
For that. Thanks. Sorry.
No problem. So this was a 36-year-old female that presented with a 2-year history of rapid weight gain, about 60 pounds. That was predominantly central, as well as the back of the neck. And she was also newly diagnosed with prediabetes and hypertension. And she was on 4 drugs, hydrochlorothiazide, the loop diuretic, as well as beta blocker and an ACE inhibitor. And that's also important to keep in mind, as Cushing and the cortisol can also have some effects on the hypertension. And she also complained of anxiety exacerbated over the past 2 years, despite medication, insomnia, difficult bearing weight on her feet, fatigue, easy bruising, hair loss, unwanted hair growth on her chin, facial acne, purple stria, amenorrhea, and also memory fog. Curiously, she also researched herself about Cushing's disease, and she underwent testing at an outside institution. So when she came to us, she didn't have any relevant past medical or past surgical history, and also a physical exam was otherwise intact, other than the features that we described before. And these are labs at presentation, if Dr. Schulz wants to comment on this.
Yeah, so I'll start from the top. Her salivary cortisols were both elevated when you look at the reference range. So she's lost like diurnal rhythm. So her cortisol is high at night, which normally you should expect it to come down at night. The TSH and the free T4 are within the T4 was a total T4. It was slightly low on, we've had a repeat one and it looked okay on a repeat one, but the TSH was okay on this one, and the outside free T4 looked okay as well. She had a DEX suppression, which she had appropriate DEX levels. I didn't put the levels in here just so it wouldn't get too busy, but she didn't suppress. So her cortisol was 22. To say that you've passed your DEX suppression as in you suppressed appropriately would be like less than 1.8 would be the level that you'd expect. And this is like incredibly high. I don't think I've ever seen one this high before, actually. So I was pretty impressed. But her AM cortisol in itself was elevated. It was 34. ACTH was elevated. It was 96. So that makes you think that it's ACTH dependent. And then FSH and LH were on the lower end as well. She wasn't having menstrual periods. Her 24-hour urine cortisol is really high. It was 900. Upper end of reference range was 45. And IGF-1 was within the reference range, prolactin, again, within the reference range. And then her DHEAS was elevated as well. So this ACTH is stimulating the cortisol axis. And then you also have like increased DHEAS with that as well. And then she doesn't have prediabetes anymore. She has diabetes with an A1C of 9.1.
Thank you. And when she presented to us, she had this outside imaging, and you can see here on the left side, the coronal T1 post-contrast. And you can see about 4 millimeter in maximum diameter with lesion with decrease enhancing on the left side of the pituitary over there. There is no compression on the chiasm and no invasion of the cavernous sinus. I don't know if Dr. Vibhuta wants to comment further.
Not really. That's very obvious. The lesion is very evident and it's not invading the cavernous sinus.
Thank you. So we have this patient that presented with abnormal labs,
I
increased
just have,
cortisol.
Diogo, may I interrupt you for a quick second? I'm sorry. I fully agree that there is no invasion of the cavernous sinus. The one detail that it is important for us to to check as well, especially in Cushing's, that we want to be, as aggressive as we can in terms of achieving disease control successfully. Is you can stop right there. That's a good there. Yeah, it's here. You can see, so the cavernous sinus on the right side, because it's easy to identify. You can see some glimpse of it here, and you can see some glimpse of it here. Okay, of course, this is just a component of it that one could call like the medial wall, although the medial wall is pretty thin. The cavernous sinus go down here, and it continues this way here. And in about here, what you see here, this is Meckel's cave actually. So in this kind of tumor here, which you see the microadenoma is mostly here. The one question that we had, and that Guy and I, we talked during the surgery, is kind of like, if we would need to do a medial wall resection of the medial wall of the cavernous sinus, which it's a more complex procedure, but all depends if we have a layer of tissue here or not. So in this case, we could have the impression that there was a layer of tissue in this superior lateral aspect of the gland, and that's why, like, we didn't plan to go ahead initially from the get-go with a resection of medial wall of the cavernous sinus. However, if the wall would be infiltrated by tumor, as observed in the surgery, then we would proceed with that. So in this case, you're going to see, thankfully, we didn't really need to do that. But anyways, just sweat.
Can you go back one image posteriorly? The one which we were showing. Yeah. One back. Yeah, stop. JP, what about that? That is up against the cavernous sinus.
Yeah.
On imaging, I just don't see any tissue separating it from the cavernous sinus.
Yeah, that's true.
Possible to tell it whether it's infiltrating the wall on coronals.
Yeah, so the MRIs that, I mean, the sequences, and actually it's, almost had the same discussion with the invasion or infiltration of the cavernous sinus. Like, it is very, very difficult to determine based on the image if there's going to be an actual infiltration or not of the wall. So, some centers, like in Stanford with one, like they've been quite aggressive with this technique, but it does add a layer of a significant layer of complexity to the clays that otherwise should be relatively straightforward. So, it is our impression that the intraoperative appearance and aspect is that should guide us about proceeding with this or not, unless if it is really like a redo Cushing that we think that the disease, the residual recurrent disease is within the wall. But in this case, like first time surgery, so we decided let's inspect intraoperatively, see the aspect of it, and then if there is some evidence of tumor adhering to the wall, then we resect the wall rather than try to just coagulate the wall. So if this was a redo case, probably would have been more aggressive. but you know, indeed, in the MRI, like it seems to be in contact, but contact does not necessarily mean infiltration of the wall.
Yeah, so how should I report this then? I mean, if I see it, what would help you in terms of, or should I say that I don't see a sliver of tissue and maybe infiltrating, or should I say just up against the cavernous sinus and just leave it at?
I think we can continue saying that above the you know, the cavernous sinus wall. In the meantime, there are, as we kind of like look at this more closely, I think there will be cases like one we had about, I think, a month ago that Kai and I did, that had like some evidence of thickening of the medial wall that was the residual recurrent Cushing's. I think we're gonna be more comfortable in stating that in the report, but I think for now it is proper to say you know, above in the medial wall.
Okay. I mean, the other option is that we can do a very high resolution coronal sequences, just like what we do for trigeminal neuralgia. We can do thin sections and see, try to see whether we can see the dura better, you know, separated out.
Yeah, I think that's quite interesting in some cases. Like in my previous institution, for example, we were doing some key sequences in coronal and sagittal reconstruction for those tumors, you know, like that had potential invasion of the cavernous sinus. And we could see some evidence that that sequence was helpful in determining that as well. So I think in some selected cases, especially the ones with either recurrent tumors or the ones that have like more infiltration of the cavernous sinus, that would be, you know, helpful.
Okay, thank you.
All right, thank you, JP. So we had a patient with an increased cortisol, increased ACTH, but that did not suppress on the dexamethasone. And there was a microadenoma on MRI imaging. So decision was made to proceed with an IPSS. I don't know if Dr. Sampson wants to comment before we move to the procedure. And I think that because of a shortage of the CRH, DDAVP was chosen as the drug to be utilized for the IPSS.
You know, it's a challenge in this young woman in her age group. This should be 90% of the time pituitary Cushing's, right? So you say, why would you do this invasive procedure? I think there were two factors here. One, it was actually really only 4 millimeters. But also sometimes we have issues with, we have the story from an outside physician, in this case, Dr. Glickman, and we are told it's 4 millimeters and she needs an IPSS, and we don't have the actual imaging. And so the pathway might have been a little bit different, but the IPSS results were very educational and spectacular, actually, for ACTH dependent Cushing's. So it was definitely confirmed that this was the culprit lesion.
Thank you. And here you can see a cartoon with the jugular vein and then the inferior petrosal sinus, the cavernous sinus, and there where the pituitary veins are. So here is just like a brief cartoon showing the hypothalamic pituitary adrenal axis. And here you can see where the dexamethasone acts for the dexamethasone suppression test, the high dose with milligrams. And here's the stimulation with the CRH or desmopressin in our case during the IPSS. And here, I don't know if Dr. Wessel is on the line and wants to comment about the IPSS.
Yeah, I can comment. I did this with Dr. Miller. The way the procedure is done is we get bilateral femoral venous access with the aid of ultrasound. Patient is awake. We avoid any sedation, we don't want anything that would potentially confound the results of the testing. We then navigate 4 French catheters into the bilateral inferior petrosal sinuses. In this case, I had trouble getting the right catheter up. Usually you can hit valves, which can make that a little bit difficult. So I was then able to navigate the left catheter in place, inject, and get reflexive contrast to the contralateral side, which I then used as a roadmap and see the internal jugular veins filling, and was then able to navigate the right-sided catheter into place. At which point we then initiated the testing and obtaining the IPSS venous samples along with peripheral venous samples.
This is an interesting piece of anatomy on this. If you go back to the previous, go one more previous run, one prior to that. Okay, run it and pause it there, or go back. Yeah, stop there, stop. Yeah, so go back 1 frame. So you can see that there is a filling defect in this petrosal sinus on the left side, that semicircular filling defect at the top, all the way to the top. If you point out, yeah. So that's a Durolus canal actually. If you look at this MR on this patient, you can actually see the canal going in that location. That filling defect which you see is Durolus canal for the 6th nerve. Yeah, that's just a small, curious observation.
Thank you, Dr. Vibhuti. We also have Dr. Miller on the line.
Yes, Dr. Wessel's description of the procedure was spot on, and the anatomy in this area is often very variable. There are some challenges to the test. You can see just looking at this that the inferior petrosal sinus on the left side is significantly larger than the inferior petrosal sinus on the right side. And in some patients, one canal is actually, or one sinus is actually atretic, and everything goes to the one side. So occasionally you can actually do this procedure, get up there and realize that you're not going to be able to get any answers because everything comes out at one point. You could, and some people have in the past, you could actually float microcatheters into the circular sinus and measure there. Some people have done, and that is an option perhaps if you only have one inferior petrosal sinus. You can sometimes navigate a microcatheter to the other side and try to get your answer that way. The results are the same, so most of the time we don't bother to put the microcatheters. The test is extremely, it's most helpful when you have a negative MRI and you're looking to because you're looking to take only one half the gland if you can. So the test's biggest utility is when you don't have any imaging. The truth is when you have a tumor that you can see on imaging, the test only correctly lateralizes about 75% of the time. And in fact, we have a case just recently where I think we have a situation in which the test falsely lateralized contra to the MR imaging. And the MR imaging is usually right about 80 or 90% of the time. So you have to take all of these things in context. There are also significant episodes of false negative tests. In general, the false negative test comes when the absolute concentration, you're looking for a rise of more than 1.4 from one side to the other. You're looking for a significant rise above periphery, and you're of up to 60 to 1. But you usually get a significant jump in the number. 10 times, 20 times. It's not usually very subtle. But at times there are false negative results, and no lateralization, even though there is a tumor and you can find it. And that usually happens when the absolute number is less than 400 picograms per milliliter at the peak output. So there are a number of things that basically it's a very good test when you need to know certain things, but it is most helpful in specific situations. And as was mentioned, the decision to go to an invasive procedure is pretty much, I think, based on the fact that for specific information that you need to know. There's very little risk to the procedure, particularly in the way we do it, in which we stay completely transvenous. One of the procedural things you do have to be very careful of is very often when you can see a little more on the right side than the left side, there may be a couple of channels, and sometimes you almost have a sort of reedy kind of configuration to the petrosal sinus in which you have a number of small channels. But if the petrosal sinus is small compared to the size of your catheter, you have to be very careful. If you actually occlude the petrosal sinus in your attempts to place your catheter, there are reports of posterior fossa strokes because some of the brainstem blood flow drains towards that, and you can get into trouble. I've never seen it. It's been written about, but in general, it's a very safe procedure the way it's done. It adds accuracy to what you're doing and can sometimes solve specific questions, but it's just important that you know what you're looking for before you go looking.
Thank you so much, Dr. Miller. So as mentioned earlier, we collected both central and peripheral venous samples at -5 minutes, so before administration of the DDAVP and then after. And then if Dr. Schules wants to comment on the labs.
Yeah, so the labs, when you look at them, you're looking for the baseline ACTH compared to like the petrosal ones. And if it's greater than 2 ratio, for like the petrosal to the plasma ACTH, then you it's a positive test. But really, once you give the DDAVP, it should be like 3 or greater. But you see it in like the thousands when it's very positive. And I know that Dr. Sampson's told me before that she's had patients that are usually in like the thousands. And for her, from even the beginning, it's 152, 179, and it goes up to the thousands after the DDAVP was administered. So very, very positive test from the pituitary, localizing to the pituitary.
And does the DDAVP have a similar sensitivity to CRH, Dr. Sampson, or?
That's a great question. I've only started using it or being exposed to these results very recently because we've always used CRH. And I don't know if it's as robust of a stimulant as CRH. And it's a great question. I need to look closer at the literature on that.
Yeah, interestingly enough, I just reviewed a paper. Of course, I cannot mention the group of authors who showed that they were looking exactly at this point of the DAVP and CRH. And actually, the results that they shared suggest that the DAVP would have a better sensitivity and specificity rather than the CRH. So it seems that the current technique we got may be better than before.
Well, the group at Mass General, Josh Hurst and some of his group, they looked at this back in 2010 or so. The supply of CRH is a little variable, so yeah, DDAVT works fine. It's interesting that it'll be really interesting to read that paper when it comes out. But there are some studies out there which suggest that the DDAVP is a reasonable alternative. Right now, it's the only alternative. So, but it generally, in my hands, in the past, it has generated what it seems to me to be proper results.
Thank you. So we obtain a CT head for surgical planning with navigation. And you can see here, normal cella.
Yeah, very favorable sinus. Sphenoid sinus quite well pneumatized, so that helps us quite a lot, and not a lot of variation in anatomy. So,
yeah,
thankfully regular case.
Well aerated sinuses. Midline septum. All right. So we have patient with a pituitary microadenoma with extensive workup indicating Cushing's disease. So we plan for an endoscopic endonasal transsphenoidal pituitary tumor resection. And here we have the video. Almeida production. JP, if you want to comment on.
Sure. So basically here we're just with Donaldson, like just finding this sphenoid ostium the left side, and this is using a mushroom punch. It helps to enlarge the sphenoid os first, and after that she went ahead and coagulated some of the posterior septal artery on the left side to allow us to proceed with the work on the left side in terms of removal of the mucosa. So this is just mobilizing the right side now, middle terminating, that's the superior terminate being mobilized. Same technique, opening with a mushroom punch, the sphenoid os on the right side. And that allows, once you open both sphenoid os, basically you can go ahead and do whatever you think is appropriate with the nasal septum mucosa. So here, she went ahead and, proceeded with coagulation that mucosa and the posterior aspect of the nasal septum, just to create that angle of work. Same maneuver on the left side. And then that's going to be removed, and that can be done with a micro shaver as demonstrated here, and then the posterior septum is going to be removed. So basically you see that both ostiums are exposed, and now with a drill, she's going to go ahead and remove all of that bone. Once again, the septation. So same maneuver as you saw in the last video. And then we're going to go ahead and start removing the posterior ethmoidal cells to further work and expose the top of the sphenoid. Once that's done, then we come along and with the drill, we start, we can stop the video right there again. This is quite repetitive, but let's stop the video. Perfect. So once again, it's going to be so repetitive that everybody's going to get tired of looking at this in every pituitary session. So left side, optic canal, left optic carotid, lateral optic carotid recess, clinoidal ICA. This right here would be the distal dural ring. Right optic canal, right clinoidal ICA, right lateral optic carotid recess. This here is the limbo, communicates roof of the optic canal to roof of the optic canal. This right here is the distal dural ring. What is right here? This is the sella that we're all very familiar with. This is the work that we got to, the space we got to work in this case. And here you would see the paraclival ICA, and here we would see the paraclival ICA on this side. And this here is the clival recess. So this is the anatomy that we need to know. So in this case, we're going to be exposing all this area, and we're going to be more focused a bit here on this left bottom and left corner. So let's go ahead. So the bone of this sella was thinned out, blue lined, and then with the kerosene, we can just mobilize that, kind of like peeling that away. And then with the drill, we're going to go all the way to the cavernous sinus here on the left side. Once that's done, the dura is open with a sickle knife. And then with, once again, the round knife, we can mobilize the membrane around the pituitary and the dura, so the inner layer of dura. And we're going to maximize the dura opening all the way to the superior cavernous sinus and the cavernous sinus itself. So here you see, whenever we open the two layers, you can get some venous oozing that you can easily control with some packing there. And then we can extend that opening all the way to the superior cavernous sinus. So that's what we're doing here. Why is that? Because we want to see all of that, all of the gland, to inspect the gland carefully. So here you see we found the plane. So this here is the normal gland, and this here is the tumor, right? So we created the pseudoplane so we can mobilize and work in the extracapsular fashion or technique. And then slowly, gently, step by step, we find the plane, we cut the adhesions, and then we're gonna go and work. So this is the like the hockey stick curette to celebrate hockey in Canada. And Dr. Susan
Go Calgary.
Go Leafs, I would say. And then with that mobilization, we work around, and you got to work in the four angles: gland, floor of the sella, top of the gland, wall of the cavernous sinus. And then we can go and pull that gently. And you see here, the one thing is that I know I'm pulling some tumor and some gland on the left side, but I'm fine because we got the gland on the right side. And here it's mobilizing the tumor away from the medial wall of the cavernous sinus to the best of our abilities. Every time you do that, you're gonna have some oozing. So you gotta, be patient. And then once that's, finally mobilized, we can go ahead and remove this chunk of tumor. And after that's done, we're gonna go ahead and we're gonna work with, there is some tissue left. I believe this was more like gland than tumor itself, but we're gonna clean that as well. And here, can you stop right there? Yeah, that's fine. Stop right there. Perfect. So this is the medial wall of the cavernous sinus that we're expecting with the endoscope now. And that's the view of the endoscope allows us to view and to really see. So if this is fully clean here, and we had that image of a thin layer of a tissue in between, we are fine. And that's what the Dr. Chai Chen and I consider, and that's why we didn't proceed with the removal of the medial wall in this case. So here, just being more aggressive with the gland to try to remove as much as possible. This indeed, we believe it was like normal tissue. And then we go and see like the posterior part of the gland. And then you see like just coagulating some of the wall. And then we went, okay, let's go ahead and remove the floor. I mean, if we remove the medial wall, why not to remove the floor of the cella if there was in contact? So that's what we're doing here. So we cut during the floor of the cella, coagulated that, and removed it. Once that was done, we just packed, and you see here gel foam, the gland on the right side. That was the cavity. And reconstructing, we didn't have any CSF leaking drop, so we just put a layer of, dural substitute with Surgicel, gel foam, and glue, and that was it.
Thank you so much, JP.
Thank you.
So this is the pre-op MRI on the left. And on the right side, you have a corona of T1 post-op, and you can see a beautiful resection. No evidence of tumor residual. And again, noted on the sagittal.
Okay, as you can see here, it doesn't have the appearance as many of the adenomas that I show you, but what you do notice is that it is a monotonous cell population in that we don't have a variety of different cells, and it is not nested. A normal anterior pituitary is nested. Additionally, you can see the nuclei are relatively round, although there is some variation to the nuclear size. If we go to the next slide. The cells are all positive for TPIP, proving that we have a monotonous cell population, and they are strongly positive for ACTH. So this would be a corticotroph type adenoma. If we were to subtype it, you have densely and sparsely granulated. This would be a densely granulated corticotroph type adenoma.
Thank you so much, Dr. Gentot. And the patient did very well and was discharged on post-op day number 1. And Dr. Schultz, if you want to comment on the post-op labs.
So she had a AM cortisol the following day of 2, and the ACTH was 5.4. So this demonstrates cure. It was an excellent response. She had sodium levels that were 136 to 140s, and the urine osmolality ranged from like 94 to 215. She was putting out a lot of urine. I was actually the one that was on taking care of her, and she was putting out a lot, but she was not looking dehydrated on exam. She wasn't complaining of thirst. So I think what was happening was just fluid mobilization after this drop of cortisol that she had. And we can see that sometimes, and it can be a lot of fluid that they eliminate, and it's not DI necessarily. She was discharged on dexamethasone, and she also started fluid restriction as well, post-op day 4 to 8. And these are post-op day 8 labs, and they all look really good. The cortisol is still very low, so this is great. It was 1.4. ACTH is undetectable. TSH, free T4 were perfect. FSH and LH. Actually, I didn't put the original labs, but they look even better already than they did previously. And then the IGF-1 was great. Prolactin was normal, and then she was slightly hypernatremic because she had fluid restricted, and she was probably still mobilizing a lot of fluid. So she's not had any more fluid restriction, and she's back on like a normal diet. She did really well, I think, overall.
Thank you all so much.
Great cure.
I have a good question for Dr. Sampson about the antihypertensive medication. She was on 4 drugs. After the surgery, how soon do you usually start, decreasing them and see how well she's responding to the decreased level of cortisol?
So sometimes some of the changes that occur in the vascular system due to long-standing hypertension mean that the patient will still require something. But once you've removed that cortisol stimulation of the aldosterone receptor, you can usually start cutting back on the number of medications. And further, you may have noticed in the notes that she almost completely came off insulin within the first 10 days.
Thank you so much.
Well, okay. I think a very nice case. I think Kai, any comments that you'd like to share as well?
No, you guys have covered it all. Sorry, trying to start a shunt.
No worries.
How far away from that surgery?
Is that a ventricular atrial shunt?
Ventricular peritoneal, then ventricular atrial.
What a day! What a day!
Yep.
And,
Talk about repetitive.
So no, I think it was a nice case. I mean, it was nice that was a cushion that we could see the lesion, which is good. We could find a nice pseudoplane, which was good, and more importantly than all of those is that we could lead to disease remission. So that's very, very good, and hopefully this is going to be like a long-standing result for this patient. But that's it. I think that every time that we can find a plane and move and push our resection to that extension, that's good, and definitely requires a lot of teamwork. So thank you for everybody, and appreciate the feedback. So Andrea, I think you want to share the updates for next week?
Yeah, next week we will have on Monday Dr. Gassi, PY7 Chief Resident of the Neurosurgery Department here at Mayo Clinic Florida, presenting the lecture, The Ups and Downs of Learning Minimally Invasive Spine Surgery at Resident's Perspective.
Perfect. Thank you. Well, thanks everybody. It's already 8:10. We're already a bit beyond time, but I'd like to thank everybody on behalf of Dr. Kio, Dr. Chaichana, Dr. Sensen, our entire team, and see you next time. Bye-bye.
Bye. Obrigado.
Oh, gracias.